Dear all, good morning and namaste. Today, I shall be discussing on very important topic from examination point of view for undergraduates as well as postgraduate ENT students. That is, hemorrhage after tonsillectomy. It is common to bleed after tonsillectomy to some extent, but with the modern equipments, hemorrhage after tonsillectomy is not a very big problem. In the past, it used to be a big problem for the surgeons and the anesthesiologists. Hemorrhage after tonsillectomy might be primary hemorrhage, which occurs during surgery. It is commonly due to injury to blood vessels, most common blood vessel being paratonsillar vein and others being tweaks of the tonsillar artery, a branch of facial artery, and occasionally lingual artery at the lower pole of the tonsil. Bleeding usually happens from the lower pole region. Sometimes it might happen from the upper pole region also. The average amount of blood to be lost during tonsillectomy is around 80 ml, but this is the old report. Nowadays, there is hardly around 10 ml bleeding during tonsillectomy. Reactionary hemorrhage occurs within 24 hours of surgery, and most of it occurs during first 8 hours. Therefore, patient has to be adequately taken care of for first 8 hours after surgery. Secondary hemorrhage is the commonest hemorrhage to occur after tonsillectomy. This occurs usually after 24 hours of surgery, commonly being on the 6th to 8th post-op day, and it is due to infection. Around 2 to 4% of all the individuals after tonsillectomy might develop secondary hemorrhage at the first week of surgery. Primary hemorrhage, as we have already told, occurs during surgery, and it is due to trauma. We can control primary bleeding either by cautery or by hydrogen peroxide pack or occasionally by ligation of the bleeding vessels, but nowadays this is rarely performed procedure for primary bleeding. We can most of the times control by bipolar cautery itself. Now coming to reactionary hemorrhage, that is the hemorrhage within 8 hours of surgery. The causes might be slippage of ligation if ligation was applied, displacement of the clot, minor clots might have blocked the opening of the blood vessels, and when the clots get displaced after surgery, then there might be bleeding. Reopening of the collapsed blood vessels caused by high blood pressure due to cough, retching, and wearing of effect of hypertensive anesthesia. During tonsillectomy, we usually perform an hypotensive anesthesia on decreased blood pressure. As the patient wakes up and as the patient retches when there is blood in the oropharynx, then there might be bleeding. Clots in the tonsillar fossa also lead to bleeding because they prevent contraction of the superior constrictor muscle, which is required for hemostasis. I have already told in my previous class. So patient is asked to chew chewing gums after surgery. After the operation, we ask the patient to gargle with dilute H2O to gargle, hydrogen peroxide gargle. That also helps to clear the clots from the tonsillar fossa. Now let's come to management of post-tonsillectomy bleeding. Before tonsillectomy, we do patient's blood grouping, and occasionally we ask the patient to have 1 pint of blood ready if required for transfusion. So if the patient bleeds after tonsillectomy, we have to ask the patient party to get blood ready and airway, breathing, and circulation artery well prepared. Patient has to be given IV fluids, and occasionally wide bore IV cannula can be kept in both hands. When the patient bleeds after tonsillectomy, investigations plus treatment have to go side by side. Investigations, blood investigations for hemoglobin, how much blood has been lost, total count for infection, and occasionally bleeding and clotting time. The clots are to be removed from the tonsillar fossa. If there is clot, the superior constrictor muscle will not contract properly. So if we remove the blood clots from the tonsillar fossa, the superior constrictor muscle might contract and there might be decreased bleeding, or the blood vessel might be sealed. The patient is asked to gargle with hydrogen peroxide dilute, which causes thermal cautery and vasoconstriction by releasing nascent oxygen. This is commonly practiced. Occasionally, we have a habit of keeping adrenaline-soaked cotton in the tonsillar fossa. That is better not to perform because after some time there might be again bleeding when there is wear-off effect of adrenaline. The tonsillar fossa has to be packed with the pressure gauze for around 5 minutes. So after 5 minutes, the bleeding might stop on itself. The patient is asked to gargle with very cold water or ice gargle. That also helps to control bleeding due to vasospasm of the blood vessels. If the bleeding continues, then the patient has to be shifted to the operation theatre for evaluation of bleeding site and its exploration. In the operation theatre, the shock is to be treated by IV fluids. If the patient requires blood transfusion, blood is to be transfused when there is severe bleeding, heavy bleeding. The head has to be low. Continuous pharyngeal suction is to be performed to avoid aspiration of the blood and swallowing of the blood as well. Ryle's tube should be inserted and ingested blood is to be removed. If we can remove the aspirated blood also. Patient has to be intubated as early as possible with continuous pharyngeal suction. It might be difficult for the anesthesiologist to find out the larynx also because there will be bleeding in the oral cavity. The cough is inflated and throat bag is kept so that there will be no more aspiration. Now it's surgeon's turn to remove all the blood clots from tonsillar fossa to identify any bleeder. Again, the surgeon has to apply the same thing that has been done in the ward, keeping a pressure gauze soaked on a hydrogen peroxide in the tonsillar fossa for a few minutes. The fossa will be cleared, and if there is any bleeding site, that can be observed. If the bleeding vessel is identified, then that can be cauterized or ligated. But in case of secondary bleeding, it will be difficult because the fossa will be infected and there will be granulation tissues and which bleed a lot if it was them. If the bleeding vessel is not identified, then adrenaline pack can be kept or silver nitrate can be applied for some time or tincture benzene paint can be applied in the tonsillar fossa. By this, the bleeding should stop, and if bleeding still continues, then we can suture both the pillars over gel foam kept in the fossa. If the bleeding still continues, then external carotid artery has to be ligated distal to superior thyroid artery, because if there is an retrograde thrombus aneurysm, that involves the superior thyroid artery and not the internal carotid artery. You have to find out at least one branch, probably the interior branch in the neck, before ligating the external carotid artery. Occasionally, we might ligate the internal carotid artery, so we have to be confirmed also to ligate the external carotid artery. If we perform this much, patient should stop bleeding. Again, patient has to be transferred to the ward. Patient is asked to avoid hot foods. Patient can take soft and cold foods, but patient has to avoid straining, retching, and coughing. So I hope this explains the method to control reactionary bleeding after tonsillectomy. Same is true for secondary bleeding also. But secondary bleeding most of the times can be controlled with IV antibiotics because secondary bleeding is due to infection. And that is not very much dangerous, but that is the commonest cause of bleeding after tonsillectomy. Have a good day. Thank you.